ACT for making it happen, and also to the rest of my faculty who are a treat, and also the delegates are coming. So we're going to do a little bit of graft choices and a little bit on technical tips in tunnel placement. Because it's training day, if you'll indulge me on one slide, I've always, as anyone who knows who's talked to me about this, or I've talked to about it, we realise we're all a product of our training and our experiences. And where do we get that from? It's what we read, it's our knowledge basis, our operative abilities in terms of develop as we do more and more, and also the people that we surround ourselves in. And that continues, that's a continuum. It's your colleagues, it's your bosses, your mentors, your fellowship, conference days. And so no one here is arrogant enough to say, this is the way it's done. No one will say that to you. Everyone should be saying, this is a way to do it, and the way that you're going to do it is the way that you're going to do it, which in other words is an amalgam of all those three concepts all put together. And so there's nothing quite like knowledge and practical experience that you then put together, and then that becomes the surgeon that you are going to end up evolving into and continuing to evolve to be. And today it's about graft and function. So what does a graft need to do? Well, actually the graft is a journey onto what the knee needs to do. And what we want to do is normalise range of motion and stability. We want to minimise morbidity and the need for revision surgery and maximise function. That's ultimately what we're trying to achieve following an ACL reconstruction. And that's important to bear in mind, given that that affects, therefore, the grafts that you're going to use. The most common grafts are autografts, and autografts, as in from the patient's own body. And when I started this operation, when I was taught to do it, was a bone patella bone, and there are a lot of good things about that. In that it's a patient's own bone, put it into a bony tunnel. That's it. You're getting bone-on-bone healing. Makes us feel good about ourselves. 6 to 8 weeks of healing, and it's strong. It's 130% initially, stronger than a host ACL. Things then evolved, particularly with arthroscopic techniques, and we moved on to using the hamstring tendons. I think there was a survey, done in 2006 by the American Knee Sports Society, and in 2006, relatively recently, 13, 14 years, 70% of them were still using bone patella bone and transtubular technique. Now, 10 years later, it's flipped, and 60% are now using hamstrings, and of those people using hamstrings, the majority of those are also using two different femoral tibial tunnels by an anatomic reconstruction. And we'll talk about what we mean by that in a moment. And Fulkerson has published and is continuing to do so a lot on the quads patella bone autograft, with or without a bony block, and that's evolving, and particularly with new equipment, new harvesting equipment, that's potentially an area of excitement. And there's two publishing at the moment views that it's giving you a little bit of anterior knee pain, and some are saying it's not giving you anterior pain. So the jury's still going. Is anyone using those? Have you used them?
No, I had one on my list, quad stent for revision ACL, and then the Danish registry published the 2-year data, and they found the re-rupture of the quad stent was 4 times the other grafts. And so I think a fair few surgeons have got nervous as a result of that and put it on hold, but there are still high volume guys who are still doing it.
Yeah. That Danish knee registry data is helpful, and not just for that, but of a lot of other conclusions that we'll talk about. But that is true. So that's the group that's saying it goes against everything that Fulkerson's been saying. So we'll see, and I think the jury is still out on that. Allografts, they don't have to be bone, patella, bone, or bony tunnels. They can be tib post or tib ant. Orthopedics generally of randomised controlled trials, but one of Mandari's paper, he took David Bial's study group and reanalyzed it and performed a deeper analysis of it in this meta-analysis. And it's difficult if you're saying to a patient who's not an elite athlete, we're going to make your knee stable, or more stable than it is now, but in trade for that you're going to potentially have a risk of anterior knee pain. And trading stability for pain, kind of as particularly in East London where kneeling is an issue, that can be something that can be a difficult sell. So the bias therefore shifted, and 90% of people are using hamstrings in the UK. And where do they put them? So yes, again, in bone patella bone land, I learned transtibial, and one of the other things that came from the Danish registries amazingly, there's no differences in sagittal plane control for a transtibial versus an anatomic. The anatomic is divided into two groups and was brought about secondary to much better tooling, much better arthroscopic equipment, and also that initiated a lot more work going into the actual individual anatomy and the bony landmarks of the ACL insertions and origins. So anatomic ACL reconstruction doesn't mean a double bundle only, it can also be a single anatomic reconstruction, and that's put into the centre, so a circular graft put into the centre of what is an ovoid footprint, and we're going to look at that soon. Again, from Fu and Bandari, there was a big push, a trend towards double bundle from Fu, and to give him his due, and I think Prim, when he came along to the POP meeting as well, just informally, he was, he wasn't big enough to step back and say, well, potentially we got it wrong there. We looked at too many parameters that weren't that relevant. So now we've taken one step back, not at all ruled them out altogether, but the shift now has swung back towards single bundle anatomic ACL reconstruction. I say that, but let's just be honest, okay? So we're using the word anatomic reconstruction, but really it's it's a dead piece of tissue. It starts off dead, it neovascularizes obviously in the tunnels, but we're harvesting it. It doesn't have a nerve supply, it doesn't have a blood supply, and so just because it's anatomic, that doesn't necessarily make it physiological. It has no proprioception ability, so it's a surrogate marker for what we think we're reproducing in biomechanics in. And it's important to appreciate that. I don't say to patients, you get your pre-injury knee back. It's a different knee to your pre-injury knee, but it's a knee that you can trust, or a knee that confers a degree of sagittal and to a degree rotational stability. Where we put the tunnels, though, will define to a degree the kinematics, and so bony landmarks and the posterior lateral femoral condyle are very helpful in order to determine exactly where that is. So before we go into that, just a normal kind of housekeeping setup. So you need to, I think it is prudent to have seen the patient before in clinic. 50% of patients with an ACL injury have something else wrong in the knee. They may have an osteochondral defect, they may have a ramp lesion, a meniscal tear, a PLC injury, and so I'm not quite at the stage where I'm, Prim sees a patient in clinic at Whitechapel and they put on the list because Prim's doing lots of hips, and then I will still see that patient in clinic. I'm not at the stage where I'm able to just see them on the day of surgery yet. Imaging is essential to pick up that additional pathology, and also, obviously for the consent, as anyone knows who's worked on our firm, please consent the other side. I'd say, I'm not sure what the number is, but every now and again you'll get a bigger patient with a smaller graft, or I make a mistake and amputate the graft, and the option to go to the other side is ruled out if you haven't put contralateral graft targets. High tourniquet in the groin crease, particularly in someone with lots of musculature, rugby players, and basic stuff like checking you've got all the concomitant kit that you need to do the operation. And as Sammy said, an EUA. There's a portal here that we don't tend to use. We did have to when we started, but on the lateral side here, slightly higher and a bit tighter to the patella tendon, in order to look around the corner to get around that condyle. And when you put the medial portal in, put a needle in first as you do, and then have some play on, and in order to determine, am I banging into that medial femoral condyle? If I put a size 8mm peanut reamer into that, am I going to take out some innocent chondrocytes on the way in when I'm reaming around the corner? So that can sometimes be tighter, and also the use of an accessory portal is no bad thing if it means that you can save a couple of chondrocytes. Good arthroscopic technique is always helpful, and I must say that having sims like this have changed totally your training. I was the absolute shittest arthroscopist in the world when I started. Year one Reg, it was like I was scoping like this, I had no clue. Some would say even now that's still the case. It takes me, I don't know, 50? 50, when you're in training. But now with these sims and using you can nerd out on it, use a little posterior medial, posterior lateral, and get into it. It's so much better for you guys than it was for us. I have killed millions of chondrocytes, I'm sure I have. And so good technique, there's no substitute for it. And there's some basic things that can make your operation a lot easier. Just a little bit about, if I may, consistency. By definition, for me personally, half of my operations are less good than the other half. And if things that you can do to stay in this blue zone and tending towards accuracy are not being in a hurry, having double checks, like a like an airline, having your pilot and your co-pilot and a relationship between the two. I'm not saying that there's Rej 1 talking to Rej 2. I'm saying that there is, you make a decision, but you use multiple contributory factors to make those decisions. So you're not just looking for one bony landmark. We're going to say, okay, I'm going to look also at the posterior or the proximal cartilage limit, or the morphology of the posterior condyle, or the bifurcate ridge, and we'll talk about those things. So in other words, the take-home is use multiple pieces of evidence to produce where you're going to go in the step. I don't want to operate slowly, obviously, but I want to not go back on steps that I've already made decisions on in the past. And there's nothing wrong with thinking twice and cutting once. So use multiple pieces of data in your operative steps so you can produce your operation on solid platforms of knowledge. And so first thing is put a knee in a position where you can reproduce it. So although not normally for routine arthroscopy, for an ACL reconstruction, I do use a side support and a bolster, because then I've got my hands free, I don't need to hold the knee, and the Rej with the SHOI, the chatting, talking about music, putting some whip stitches in an ACL, but we're both looking at the screen and there's one constant way the knee's at 90. This knee is at, it's an extension, it's at 0. And I actually don't like this for residents or registrars ridge. I think it's a bit disparaging. It's the lateral intercondylar ridge, and the cyan arrow points to the posterior cartilage margin and the proximal cartilage margin in red. So let's go to 90 degrees and look at a knee. From now on, we're going to talk about knees when they're at 90 degrees. And we know that there are two, you're bored to death of it, I'm sure, but there's two bundles, the anterior medial and posterior lateral. They derive those names from where they sit on the tibia, not where they sit on the femur. They flip and they rotate around each other. And so the shaft of the femur is going this way, in towards the lap, and you can see, and there is a white line that's not a good choice of colours, a lateral intercondylar ridge, that's the so-called resident ridge, but we're not going to call it that now. And posterior to that are the posterior lateral and anterior bundle, and in between the two that separates them is this lateral bifurcate ridge. And this is a right knee at 90 degrees. And we're going to get to know these intimately. So this is the left knee at 90 degrees. And we've got the centre of the posterior lateral bundle, the centre of the anterior bundle, and if we were doing a double bundle, anatomic reconstruction, that's where we would put them. If we're going to do a single bundle, then it will go in the middle of that ovoid footprint. What does that look like arthroscopically? You can see the black arrows represent the lateral intercondylar ridge. The white arrow is the bifurcate ridge. The PL is the posterior lateral, and the AM is round the corner. This isn't something you aptly comes everywhere in orthopedics. It's not something you just look at. You also move. You look, feel, move. So you feel with your probe, and you can run over the ridges. You fall over the back of the lateral femoral condyle. Get to know that area. Put your scope up close to it. And as we see, we'll move portals too. But we're not just, in our checks, we're not just using one thing, we're using multiple things. And in 10% of patients, approximately, the fuse group has demonstrated that there is no obvious lateral intercondylar ridge. And in even 50%, there isn't a discernible bifurcate ridge. So in those instances, clearly, the morphology of the posterior condyle is very important to look around the back so we can so we can be confident that we're putting it in that blue zone, that reproducible position. In a denuded, all the soft tissue has been stripped out, and these are guide wire tips, and education is a degree of repetition, but look at it in relation to the posterior cartilage margin, the proximal cartilage margin, and the black arrow, which is the lateral intercondylar ridge. We've got the centre of the posterior lateral, centre of the anterior medial, and that anatomic spot. Take it to a cadaver, and we can see the cyan arrows are the proximal cartilage limit, and we've got the intercondylar ridges, the centre of the AM, the centre of the PL, and then the where we put a single bundle. But that's quite stylised and idealised. It's not necessarily the case. Lateral portal. I think, and actually quite late in early in my consultant career, I remember. I think it was Prim going to York that demonstrated the value in considering other holes, and putting in a scope through the medial portal demonstrates. You can see here. Could that be it? Would that be the centre of the of where you put the? Hang on a minute. Let's go medial portal, and we can see no, it's here. And then, although we don't routinely do it, this is a 70-degree scope in through the lateral portal again. Going back to that, it shows it's clearly anterior to the intercondylar ridge and a long way from the posterior intercartilaginous posterior and proximal cartilage limits. Old image, apologies, but this is taken right up against the intercondylar ridge that you can feel the posterior. And look, that would be way too posterior, and that's way too anterior and way too high. So something in this region would be something that would be aiming for. And obviously, you're at the stage where you're thinking ahead. You're thinking to yourself, well, how much posterior cortical bone do I want to leave? And literature varies. Some of it says 7 mils, some of it says 3 mils, in that kind of ballpark. And the things that are going to affect that clearly are going to be things like your graft width. So here's an example where maybe I got the graft width a bit wrong. Maybe that's erring a little bit posterior, given that I think that's like 11 mils, or quite a big radius of ACL graft going in there. Any questions about femoral tunnel placement? Okay, and then tibial tunnel. So I think it was bed. Lots of the excitement carries on, and the tibial tunnel, by all means, has a huge impact on how that ACL is going to relate to the bony landmarks in the knee. And if we go over the top of so if you're looking over the top, you can see the take home really is the PLB, which is the posterior lateral bundle, and the anteromedial bundle. And that's quite a nice idea. A long time ago, I quite like that box idea, where you look at the centre of the two, or you feel, look how anterior it is. I mean, all this thing about, the front of the ACL is level with the anterior horn of the lateral meniscus. But it's such an elongated structure. You can get 1.5, 2 centimetres of footprint. And also there's a huge degree of variability. You can show that it's 5 mils, 7 mils posterior to that. And this is an operation that involves the posterior aspect of the knee, and erring slightly posterior is usually a little bit better in life than too anterior, because a block to extension is a terrible thing to produce in someone with a secondary cyclops. So I've got a bias, I guess, in that I do go a little bit more bias in the centre of the box in that instance. The ramifications of having tibial tunnel malposition are significant. If too anterior, it's roof impingement, not being able to extend a knee. It's the first thing to work on in rehab after an ACL operation, is getting locked back and full extension. And then you can end up bending over your PCL if you're too posterior too. I just have to say thank you. And any questions?